Done. Okay, thanks, Erica. All right, Paul, take it away.
All right, great. Thank you very much, Brian, for all those kind words, maybe too many kind words. I appreciate it. I'd rather have the introduction just say, this is Paul. He's a good guy to drink beer with. So, I want to thank the organization for the invitation to speak, and really look forward to sharing a few minutes with you to talk about an important topic in simulation. The title of this talk is Saving Lives Systematically, Simulation as a Patient Safety Tool in Healthcare. And what I kind of want to do is talk about the aligning simulation as a patient safety tool, and talk about some of the reasons why it probably hasn't emerged as a globally accepted kind of mandated simulation implementation for patient safety, and what we can do as simulation professionals to move that along. That's what I'm hoping to cover here in the next half an hour or so. So starting things off with disclosures, I do some personal consulting, but I don't think there's anything that will conflict with what I'm talking about today. And all opinions in my talks are mine personally and may or may not be representative of my affiliated institutions. So Pittsburgh's a pretty nice place, actually. Most people don't know it. I didn't know it before I moved here in 1997 with an intention of staying 4 years. Yes, here I am now in 2021. I highly recommend to visit the Pittsburgh when it looks like this. In the winter months, it kind of looks more like this, and it's a little bit less fun, but still a great place to live. So again, thank you, and sit back and let's get started. What I kind of wanted to frame it and set it up is just give a real brief overview of UPMC and Wiser, not so much from a infomercial perspective, but just to kind of give you the perspective that I and my team kind of how we approach simulation and where we come from. Talking about what is patient safety, a few words on the scope of the problem for patient safety, and then look at some of the opportunities for patient safety as they are related to simulation. I've had a number of careers, as Brian had mentioned. I was a paramedic at one point in time. I also had another career as a DJ. That's my brother and I back in the 80s doing this DJ gig. As Brian mentioned, I was in the Navy, and I was stationed on an aircraft carrier for 39 months of my 7 years, and it was a really, really cool experience, and it's kind of where I got my penchant for education. My current role is kind of unique. I practice emergency medicine and have been the director of Wiser for about 16 years now. And I also, the unique part of it is I have one foot in the simulation camp and then 1 foot in patient safety for our corporate offices across the UPMC health system. So I am deeply involved in the events that cause harm to patients, the surveillance of the same, and improvement of the system as it relates to patient safety. Just a few words on Wiser. Sorry. A few words on Wiser. We're jointly connected basically to the University of Pittsburgh on the left, and you know it's sort of like the classic affiliation in a educational university, where insofar as we are worried about the schools of school of medicine, school of nursing, school of pharmacy. We're doing a lot of teaching of students in terms of them coming to us for their simulation needs and some educational research. Our single biggest user at Wiser by room hours is the University of Pittsburgh School of Nursing, and School of Medicine second, and then the School of Pharmacy is third. On the UPMC side, this is large healthcare system that I'll give you a few facts and figures on here in a few minutes, but essentially We have about 30 acute care hospitals and 10 specialty hospitals. And inside of the UPMC part of our mission in Weiser, we support the hospitals. We engage in lots of patient safety training programs, teaching of physicians, resident physicians, other healthcare providers, and do a lot of continuing medical education, continuing professional education for non-physicians as it relates to simulation efforts. And those two sort of alignments are the parents, if you will, of Weiser. For the purposes of this talk, though, we're just going to focus on the UPMC side or the health system side. Not that I don't think the school side is not important, but when we're talking about patient safety, we're talking about where the patients are for the most part, and that's on the hospital side of this equation. So Weiser has a main campus that's about 16,000 square feet or 1,600 square meters. That's where our teaching, educational development, kind of the headquarters, a lot of our simulation-based activity occurs. We have also a series of satellite centers, which actually I got to make room for two more that just came on board last month, that are located inside of hospitals, inside of our health system. So they're kind of like mini Weisers that we are, we like to say, taking simulation to the people to execute it so that more simulation can reach and more of our providers. UPMC is very large, as I mentioned. We have over 90,000 employees and about 11 or 12,000 nurses at the bedside. So it's a daunting task when we roll out education, and we're still learning, I guess, is a good way of how to do it and how to get it out to the people. Weiser is accredited by the SSH in all 5 areas of specialization. We've been accredited for a long, long time also by the American Society for Anesthesiology, and is part of the Simulation Education Network. In a typical year, we did about 2,130 classes. This is 2019 data. 2020 was a bit messy for everybody, so I'm kind of trying to give you the average of normal, if you will, year. So we did about 19,000 educational encounters, which counts 1 student coming through the door for a scheduled piece of instruction. And about 5,300 people were unique individuals in some sort of student role in simulation. So shifting gears and talking a little bit about patient safety, probably a lot of you have seen some of the fanfare in the media and the common press that, medical errors are the 3rd leading cause of death in the United States, and graphs like you see over here that demonstrate medical error as the 3rd leading cause of death, with 250,000 deaths attributed to error. And there's a lot of fanfare associated with this for good reasons. When patients are harmed and they die, it's a very newsworthy thing. It's a very important thing. The news helps to keep pressure on the healthcare systems to improve and so on. But this particular study underwent a lot of scrutiny, and there's some controversy around it because it's an epidemiologic study. So it's, what counts and what doesn't count is always kind of brought into question. But I like to say whether this number is 250,000 or 25,000, so if they're off by an order of magnitude, which I doubt, we have a lot of work to do in terms of keeping patients safer. There's about 1 in 3 hospitalized patients, so inpatients we're talking about here, 1 in 3 will experience an adverse event, and 6% of those will prolong the patient's hospitalization and or send them home with permanent or temporary disability or death. So that kind of helps to bring it into perspective of the work that we need to do. And again, the statistics and the numbers I'm giving you are just about inpatients. It doesn't even count the outpatient environment. So in 1999, most of you may be familiar with the Institute of Medicine's report, now the National Academy of Sciences, to err is human. And then they quantified about 100,000 Americans die annually from medical mistakes. This is a number that I think more people are confident with, but so it's extraordinary to think that that amount of people are harmed by from seeking care. Simulation is mentioned in this report 18 times in 1999. But I would argue, and I argued in my editorial for simulation in healthcare in 2018, despite this, and I was talking about that Institute of Medicine report, there has not been widespread, systematic, consistent adoption of simulation into the patient safety efforts of hospitals and health systems. So I want to ask you is like, how can that be? How can the Institute of Medicine say 18 times in 1999 that simulation is part of the answer for 100,000 people annually dying from medical care? And here we are in 2021, and I would say, this article that I wrote was in 2018, so 3 years ago. The statement is still the same. There's not been a widespread systematic adoption of simulation, and I think that we need to be thinking about it, and as professionals in simulation, working on moving that forward. So I think hospitals and health systems, they oftentimes don't fully understand the capabilities and limitations of simulation. They think of simulation as an expensive education tool. Okay, when I say they, I'm talking about the C-suite, right? The bosses of the hospitals. They know that simulation is expensive in terms of a quote teaching modality. They don't routinely have people from simulation programs helping with the decision. So there's not a lot of seats at the C-suite level for simulation program leaders and simulation folks, and that helps to accentuate all the problems listed above. There's no mandates, from either states or federal governments or accrediting bodies to say that simulation should be implemented, or either a strong recommendation or requirement. And we in the simulation community have not brought forward convincing data that simulation can save money. So in C-suite terms, that means it's unclear return on investment. So these are some of the challenges. So how can that be? How can we be so far along 22 years after that report and still have this unclear return on investment in the community? Part of the challenge is it's a one center focus. You've seen one simulation center, you've seen one simulation center. Everybody's kind of focusing on their own thing and their own, doing their own thing, which makes it harder to do good systematic research to really generate the numbers that will help with return on investment. And then the other thing is, and this is where I really have been, the last few years have been doing a lot of advocacy work, is simulation programs are not aware of the true patient safety issues. They might know the big pictures, or they might know one or two, but they don't know the true patient safety issues. And the challenge is you have to know the big patient safety issues at your hospital, not just like what you read, not just what you hear about nationally, at your hospital. Instead, most simulation programs simulate what they are most passionate about, as opposed to what the true patient safety issues are at the institution. And simulation, this is another kind of drawback of simulation in terms of this conversation, that simulation programs are immersed in education, and they're focused as a primary education modality. And they worry about things like realism and debriefing and safe learning environment and all these kinds of educational terminology, which basically means the chief financial officer of the hospital is going to yawn. And that's like tough talk, but it's kind of true. And when they start simulating what they can simulate instead of what they should simulate to provide ROI for the hospital, they sort of get subjugated and not viewed as a true partner in quality and patient safety. And then you get the C-suite decision makers thinking, oh, that's an education center. Oh, that's just the sim center. As opposed to recognizing that they could be a true partner, the simulation program can be a true partner in reducing the risk to patients and improving patient care, improving the risk profile, decreasing the amount of litigation that goes on, et cetera, and all the good benefits of simulation and patient safety. So talked a little bit, or I talked a lot already about patient safety, and I just want to review, some high-level aspects of patient safety. Reducing unexpected patient harm that occurs during the delivery of healthcare is the most generic definition of patient safety that I can come up with, but I think that it's one that works really well. And what we're trying to do is say, patient care, the delivery of healthcare is a dangerous proposition for the patients, their families, et cetera. And I would argue for the physicians and healthcare providers involved as well. And what we want to try to do through systems designs and improvement processes is reduce unexpected patient harm that occurs. A number of years ago, there was a sociologist from Scotland. His name is James Reason. He came up with the Swiss cheese model as it applies to healthcare safety. And I think that some of you might know about this, but just a quick review. You have these slices of Swiss cheese, and through the slices of Swiss cheese, this arrow is coursing. And at the bottom left, is the arrow striking a patient, and that's when actual harm touches the patient. Well, the idea of the Swiss cheese model is that there is a multiple wax at the apple, if you will, in aligning the Swiss cheese slices so that the holes are smaller and not in direct alignment with each other, so that the arrow will deflect away when it hits one of the slices of cheese. And these slices of cheese are all systematic changes that can be made inside of a healthcare system to reduce harm coming to patients. Things like staffing, policies and procedures, the equipment that's available, the training that's available, the surveillance systems that go out and look for patient safety events, or what we call latent safety threats. So it's the snake in the bush for the patient, if you will. So we want to find these things before they're actually able to bite the patient. So let's just kind of look, and this is in no particular order, no particular scientific method. I just pulled a few random articles about simulation that probably a lot of you are already familiar with. One of the most famous ones is simulation-based mastery learning reduces complications during central line placements in the medical intensive care unit. Other studies, hospitals with more active participation in conducting standardized in situ mock codes have improved survival after in-hospital cardiac arrest. Another one is a quality initiative that was in simulation healthcare, a system-wide reduction in serious medication events through targeted simulation training. So I just gave you 3 random examples that you could pick up in any journal and read. My question to you is, how do we know if we are doing the right simulations? I gave you 3 very different approaches to simulation. How do we know if we're doing the right stuff? What we need to do is monitor the pulse of our own organization and find out what are the problems that plague our own organization. In some cases, they will probably line up with national problems like central line placement issues, central line infections, and ventilator-assisted pneumonia, and lots of things. But then what you also quickly realize is the safety profile of your own hospital is not going to line up line for line with the national standards. And the C-suite of your particular hospital, where you're caring for patients, they are very dialed into their own problems, and they are working up and getting up every day to fix the problems in their hospital, your hospital. And you need to be dialed into how that works at your hospital so that you can make sure that you're simulating what you should be simulating, not what you can and like to be simulating. And this is sometimes a big pill for people to swallow, but I'm arguing that that's why we haven't really moved the ball forward in the last 20 years with regard to a systematic improvement process brought forward by simulation. In simulation in healthcare, in 2007, David Gaba talked about the future vision of simulation in healthcare. This was in 2007, okay? David Gaba is an anesthesiologist, one of the founding members of the Society for Simulation in Healthcare. He's from Stanford. Some of you may know him or know of him. And in this editorial, he said, using simulation to improve safety will require full integration of its application into the routine structures and practices of healthcare. And he goes on to say that the costs and benefits of simulation are difficult to determine, especially for the most challenging applications where long-term use may be required. And that, my friends, is the challenge. Okay, a lot of people in the C-suite and the healthcare industry these days have very short attention spans, running a 90-day set of books forward and looking back 30 days, and he's got to keep moving. And what David's arguing is to do this systematically, we need a full-scale integration into the healthcare systems with our simulation partners to be able to work on this and create impact and make it work over time. So in the same article that I referenced earlier, editorial that I wrote, I said partnering with quality and safety experts of affiliated systems vis-a-vis hospitals will catalyze deeper involvement with and shared learning with respect to existing problems and simulation opportunities, okay? And this is important to think about, partnering with quality and safety experts. I'm saying partnering, meaning getting a seat at the table, because I argue that simulation needs to be hardwired into the system to function at maximum effectiveness for patient safety. Okay, it needs to be wired in. If you look at this, you know, this is my metaphorical switchboard. You know, you have the Department of Nursing, you have the Department of Finance, you have the risk management, you have the lab over here, you have simulation. It doesn't look any different. It's part of the normal operations of healthcare, okay? And this is really important because we, at the moment, look like this. We look like luggage on the back of the car strapped on as something extra. And we want to really take up a position where we are integrated into hospital systems so fully that we don't look like that luggage on the back of the car. We are part of the machine that runs the hospital and runs the patient safety, the quality improvement issues that go on that help to keep our patients safer. So how do we do that? We need to connect with institutional data, as I've argued already. We need to be thinking about what are the harms, what are the errors that occur in my hospital that I work with in my simulation center? What are the quality problems? Are we getting sued? If so, how often, how much, etc. You know, these are three areas of data that are critically important for simulation programs to have direct access to be able to make a convincing return on investment argument for the healthcare system. Okay. Other opportunities we can find for by looking for them in situ simulation. I'm going to tell you a little bit more about our program in a second on that. External agency mandates. So maybe the Joint Commission, maybe the Department of Health in Texas, for instance, would put forth mandates for simulation. Networking, professional associations like you guys are working on forming here, getting more people to the table working together towards a common goal is going to improve the influence simulation can have as we move forward. So, alignment, strategies, and communications. If you look at this simplified diagram on the left, there's probably a hospital president, CEO, chief exec, some kind of title like that. There's going to be a Department of Physician Affairs. There'll be something to do with nursing affairs. There's going to be risk management, legal. There's probably clinical departments. There might be an education department. There's quality. There's safety. These are entities inside the healthcare system in a typical hospital or typical health system. And the simulation program, unfortunately, sticks out here. And it's kind of that luggage on the back of the car, if you will. It's the add-on. Sometimes it's tied up with the education department here, okay? And the challenge with that is, just quite frankly, speaking bluntly, is the education department usually doesn't have a lot of political power or money. So that is one of the reasons why it's challenging to advance the cause of patient safety with simulation, if there is a tight linkage with the education department inside the hospital. Instead, what we need to do is focus on these folks over here and look at quality and safety. And we need to get and build meaningful relationships with the quality and safety leaders of the hospital, because they are the ones that the C-suite, the president, and all the other top execs are kind of counting on to fix the quality and safety issues that plague a given hospital or care facility. So we want to create conversations. We want to create flow of information that goes to the simulation program. And the simulation program can analyze them to decide when can simulation play a role, which particular instances should we engage in, and also be able to advise when simulation isn't a good solution for a given problem. And then we also want to create a 360-degree communication so that the simulation program is giving information back to quality and safety, whether that's advising on future programs, whether that's advising on the efforts that the simulation program has put into the hospital to address the quality and safety issues that are unique to this particular hospital. That, I believe, is the key to establishing political power and garnering more resources for the simulation program for improvement in patient safety and improving the quality of delivery of healthcare. So in essence, what you're doing is you're moving the simulation program closer and closer and closer, and hopefully getting a seat at the big table inside of this bigger box, so that you become like that circuit board earlier. You're just part of the process. You're part of the everyday process of the C-suite thought processes of your particular hospital. So you want to be able to align with the institutional goals and available data. And then when you do create a solution, so this is kind of a block diagram of our central line program at Wiser that we started a long time ago, and how we found out the scope of the problem from the safety folks. We went through our curriculum development process. We trained a lot of people, and we reported back to the health system on the regular basis. We always want to tell the story. We always want to make sure that people know that we are creating value and making an impact in the safety and quality spheres that matter so much to everybody. So with that being said, I want you to sit back and think just for a second, is what makes a simulation a good solution? I'm just going to pause for about 20 or 30 seconds here so that you can think about that. So what makes simulation a good solution? Well, for one is it's necessary, it's needed. And if we're talking about patient safety, because that was the title and theme of this talk, what makes simulation a good solution is if it's solving a patient safety problem, okay? And the other thing to think about is oftentimes simulation is never the sole solution to something. So embracing and working with others to figure out how do we create this holistic solution that probably involves simulation for patient safety. But step one is understanding definitively in a scientific way, a data-driven way, that this is a problem at my hospital. This is a problem in my hospital, and I think we can bring simulation to the table to help be a part of the solution. Okay, that's what makes simulation a good solution. When we need that immersive learning, when we need to figure out what's going on, when we need to use simulation as an assessment tool to figure out latent patient safety threats that I talked about earlier. But we want to make sure that it is that what we're going to simulate is needed, and or can we use simulation as an assessment tool to determine where our weak spots are. And that gives rise to the in situ programs that we talk about a lot. At our program, we performed 110 assessments of different hospitals throughout our system in the last 24 months. We're using simulation as an assessment tool to look at systems and environments, a little bit about the individual work that goes on and how do the teams function. But the biggest part is this one. And this is a big pill to swallow for some people as well. And this is sort of pivoting that we're not using simulation in the traditional sense as an educational tool as the main objective. Yes, we give a little bit of education when we do our in situ programs, but what we're really primarily focusing on is measuring and looking at the systems and environments of care, looking for those ways to improve, looking for those ways to build up resilience for weak spots in the system, and advise the hospital C-suite on what to invest in for training for other patient safety issues that might come up. Because if they put all their money in things that they're already doing well, then that's not going to help solve anything. But if you find things using simulation as an assessment tool, then you can flip it into a better solution to find the real problems that are plaguing the hospital. So after we do our in situ simulation, we thank people for participating. There's these cards that come from me as the chief safety officer for the system, and we hand them out to each individual that participated. We let them know what goes on with the videos. We let them know that this is primarily a systems assessment. We thank them for participating. We give some high-level feedback, but not like kind of the debriefing and long education process that you would think about if you were like at a national simulation meeting, because we don't have the time to take these practicing professionals offline for that long. We want to keep things brief to minimize the impact to clinical operations. We bring things back to Wiser. We do a very sophisticated analysis of the video and come up with a report that goes back to the hospital leadership. That's what we do. So I would argue that we try to be a true partner in patient safety, partnering in that metaphorical sense of that circuit board looks like all the other ones. Partner in the sense that we have representation at various high-level committees throughout our system. We have maturely developed sources of information that you need to do at your simulation program to look for true value, to look for things that you can bring value to your C-suite, and help them process and let them know when simulation is part of the solution, let them know when they should take a pass on simulation, and then help look for those prioritization of patient safety events or ideas where investments can be made to improve the quality of your particular story. And then don't forget to tell your story. Tell your story of the value that you bring to your healthcare system, not by education, okay? You're bringing value in a holistic sense to improve quality, to improve patient safety, and this is how I've done it. This is the picture of a patient safety report that we published for our last 18 or 24 months of work with the UPMC health system. That is in hard copy. It's also downloadable as a PDF. If anybody wants it, you can send me an email or something and I can get it to you just for an idea of how we do our storytelling. But what you'll notice is the storytelling is linked to problems that we know exist in our own healthcare system and solutions that we've created in our own healthcare system, partnering with quality, with risk, sometimes with education to develop these solutions to help improve the safety and the quality. So I think I'm about on time, and I promised the organizers that I would stay perfectly on time. And I tried to do that. And this is a whole bunch of contact information for me on Facebook and Twitter and LinkedIn and whatnot. And I think someone put the Wiser website in the chat if you want to stop by and take a look at that. Otherwise, thank you for giving me the time to talk to this organization. It was really fun at the beginning when I heard you guys chit-chatting about the future of Spot and what you're doing with it. It kind of reminded me of about 20 some years ago when we were forming the SSH and all of those conversations. So I think it's exciting. I think there's strength in numbers. I think when people are working together for a common goal, that we can truly make a difference in the quality and the safety of healthcare, as well as, again, I was not slighting the education side of simulation as much as just saying, focusing on how we can move things forward with simulation in the patient safety environment. So with that, I will stop and turn it back over to the organizers. Thank you very much.
Thank you, Paul. I know that we have some questions in the chat. Erica, do you want to take care of those and presenting those to Paul?
Yeah, I can jump in here now. So John Wallace has a really good question as far as, is there a way that you think the medical schools and colleges should be able to connect with safety teams as well as education teams to improve the safety?
Yeah, absolutely. John, that's a great question. And again, I was trying to focus on the hospital operation side of things, but I think that there is a ton of work to do in terms of recognizing the weak spots in today's education programs for the physician pathway for all healthcare providers, and try to get what I call the safety IQ, the teamwork IQ, the communications IQ, more polished for the future. Our current chief legal officer for risk, he came to UPMC about 15 years ago, or 16 years ago, I guess it was. He toured Weiser, and we were talking, and I said, Rick, what do you think the top 3 problems are with he sees all the risk management stuff, and he's the chief lawyer for all of our malpractice and claims against the system. And he said, communications. Communications doesn't turn overnight, and oftentimes in simulation we think of doing things, and we kind of add on communications at the end. It's like the last learning objective. Oh, and by the way, we'll talk about communications and teamwork. And I think that there is a whole lot of work to do in the pre-professional learning pathways of all domains of healthcare to bring simulation in to improve the IQ of people from a systems safety perspective, which would include communications, teamwork, and team leadership. So I absolutely think there's a place at the table for that.
Perfect. I believe that's the only question directly in the chat that I see, unless I'm missing something, Brian. Does anybody have a question for him that they may like to ask either via the chat or verbally?
I think there's a question in Erica's chat I'm looking at. What is your recommendation with fitting in with other board members? That's a spot
Yeah,
question.
that was a spot question. That was supposed to go to Billy, that didn't make it directly to her, but that's okay. You mentioned a lot about the C-suite, which I think is really important. And this is something that I learned in my master's program, and me working in higher education. There's not necessarily a direct threat to our department, but definitely you see that a lot more in the hospital setting, where education typically is one of the most threatened areas and one of the most first cut areas. Would you have any recommendations for those that do work in the hospital to have buy-in, not just within their own department, but for the C-suite as well, and really just, again, advocating as much as they can for that?
Yeah, it's a great question. As I kind of said earlier, and again, I wasn't trying to slight educators, but in general, education doesn't have usually a lot of money, and they don't have a lot of power. And the power is on the quality and the risk and the patient safety improvement side of things, particularly now that those activities are directly related to healthcare finance and the cost of healthcare in this country. And so I think that as long as you lead with a narrative of simulation's a great education tool, it sort of disempowers you, as opposed to leading with the idea that simulation is part of an integration strategy that will improve quality and improve patient safety. And when you think like that, and when you change the narrative that way, you get the attention of the chief quality officer, the chief safety officer, in a way that in a way that doesn't garner the same attention if you're talking about education. I heard a chief financial officer from a healthcare organization say before, I know you do great education, but I already pay to have great smart healthcare providers. And it's kind of a sad mindset, but I think that it's not so far off from how people think in the C-suite. And I think that they're not trying to be mean people as much as they're just trying to balance a lot of things in terms of finance and the future of their existing organization and so on. And so they think all these smart people, physicians and other healthcare providers, are coming to the table. They don't realize of the importance of ongoing training, professional development activities, the whole idea that we can use simulation to help steer investments properly. And if you think about it that way, from a systems solution perspective, I think that you'll get more attention and perhaps work your way into getting a seat at the table, is like my metaphor that I keep using with critical decision making, to help bring understanding of the capabilities as well as the limitations of simulation into the potential work as a solution for the given system that you're in.
Very good. Anybody else have any questions at all that you can think of? And let me get to here, and for some reason, there we go. Thank you very much. Paul, I can't thank you enough for agreeing to speak today about patient safety. And the several things that you said resonated with me, and really, really critical is that you know, we're the luggage on the back of the car, and seen as the extra bit. You know, that can happen both in the hospital and at the university setting if the leadership is not fully on board with simulation. So really critical information. And then what makes simulation a good solution? I absolutely love that, because you know, I'm going to take that to my team and start before we even begin our next semester at the university, I'm going to pose that question to them. I'm going to borrow your question, if you don't mind, and pose that to my team, because they couldn't be here today. But thank you for agreeing to speak. Thank you for your words of wisdom, which are amazing. Thank you, everyone, for being here. Does anybody have any last comments? Jeremiah, do you want to wrap us up?
Sure. I think that was a great insight on where can simulation really um, impact an organization, and it's to talk to the right people. So that was a great insight that I've never heard before, and I think that's really going to help all of us. But once again, we just want to say that we would love some more help and creativity on our spot planning committee. You can reach out to Brian, Erica, or Laura Tilke for that. Also, just go ahead and open up your camera and scan that QR code so you can start filling out that form. And also, if you have benefited from this, from Spot in general or today's meeting, please scan that QR code for that as well. Thank you guys, and hope you all have a great weekend. And that's all I have for now. Thank you, Dad. Thank you, Paul.
Absolutely. Thank you very much for the organization to invite me. And Brian, look forward to the next time we see each other in person. It's always a good time.
Absolutely. Thank you again, Paul.
Bye-bye.
Have a great weekend, everyone.
Thanks.
Bye, everyone.